Transplantation of hematopoietic stem cells is curative for a large variety of hematological malignancies, otherwise lethal. The curative potential of transplant is actually immune-mediated, and the reaction comes from donor mature T cells that fight minor and major histocompatibility determinants in the cancers of the recipients. Unfortunately, this type of reaction can also affect normal body tissues and organs, and this reaction is called graft-versus-host disease when it affects the skin, liver, gastrointestinal tract, and lungs. The incidence of graft-versus-host disease is roughly 50%. 50% of the patients are affected, and a quarter of them actually would die of acute graft-versus-host disease, complications of acute graft-versus-host disease, infections, organ failure, or evolution into chronic graft-versus-host disease. With expansion of the donor pool for transplantation, the incidence of graft-versus-host disease has also increased. However, the way we treat it has actually not changed that much. And the key elements for treatment of established graft-versus-host disease, it remains with systemic glucocorticoids, prednisone or analogs. If graft-versus-host disease involves less than 50% of the body surface area of skin, we just use topical steroids. If graft-versus-host disease involves the stomach without diarrhea, we can use beclomethasone that is also non-absorbable. But if diarrhea is involved, liver is involved, or more than 50% of the skin is involved, then we have to use systemic glucocorticoids, prednisone or others. In patients that have good performance status, we can actually use an outpatient regimen of oral prednisone of 1 to 1.25 milligram per kilogram per day in 1 or 2 divided doses. But in patients that have compromised performance status because of diarrhea, dehydration, concurrent infections, we keep them in the hospital, and these patients usually have more aggressive graft-versus-host disease. We use intravenous formulations of glucocorticoids, predominantly methylprednisolone, at the dose of 2 milligram per kilogram in 2 divided daily doses. After the treatment is begun, we hold the dose steady for a minimum of 7 days and up to 3 weeks to assure the patient are continuing to improve before we taper the prednisone or methylprednisolone doses. The taper is usually started at 10% of the initial dose and continues on a weekly schedule after the patient is assessed and we assure that the continuation of improvement is observed before we taper the glucocorticoid dose to the next lower notch.